So everyone, if you want to switch your cameras back on and we can get started on the second lecture of today. We're very lucky to have Dr. Fiona Gupta, one of the neurology attendings here and movement disorder specialist, talking to us about this. Whenever you want to get started, and thank you so much for joining us today, Dr. Gupta.
Oh, it's a pleasure. I wish I could be there with you guys in person, but hopefully soon. But this is a great format. So it's a pleasure to be here. I am a neurologist. I am a movement disorders specialist. I've been in practice about 16 years and have a main area of focus on Parkinson's disease, movement disorders, and in particular, things like deep brain stimulation and neuromodulation for various movement disorders. So, the topic today was fairly broad in terms of movement disorders. And, I thought we could narrow it down a little bit, maybe to do a little bit of a deeper dive into Parkinson's, but we could definitely address other movement disorders as well in terms of how I evaluate, how I treat, and basically, the ultimate kind of landscape in movement disorders. So when you're referring a patient to a movement disorder neurologist, these are some of the conditions that we treat. I start Parkinson's disease, Parkinsonism, and it's tremor, because typically those are really the main conditions that we treat. Parkinson's disease right now is about 1.5 million patients in the US, and actually that number is going to even grow over the next decade or so. And I think that's a couple of different reasons. Patients are living longer, they're being diagnosed earlier, and that we actually have more treatment modalities. So, Parkinson's is really something that you're going to all see throughout the course of your careers. And I think it is important to know sort of when to refer, how to diagnose, how to treat, and so on. But it is a very common condition. Dystonia is another movement disorder that you might come across. And actually, this is more common than we think. We just think it's very unrecognized and, oftentimes underdiagnosed. But dystonia essentially is sustained muscle contractions. And, there's two types of dystonia: generalized, which is usually more pediatric, that occurs in, segmental body parts, or it involve the whole body, or focal, which is more adult, which is more like cervical dystonia or torticollis, is a common type, or even like a toe curling dystonia in certain conditions. Huntington's, we see a good amount of Huntington's patients here. Chorea, which is writhing movements, is usually the movement disorder that occurs in HD, but then it's a triad of movement, cognitive, and also mood. And it's a tough condition to treat, but we do treat quite a few patients in Mount Sinai. Ataxia typically comes from the cerebellum, whether it's cerebellar loss or ataxia syndrome. But in order to really assess for ataxia, you have to do a really super good gait evaluation, which we can talk about. Essential tremor is the most common type of tremor, the most common movement disorder, actually. There's about 5 million patients in the US. Typically, the difference with essential tremor as compared to Parkinson's is that it's a bilateral tremor with action, where Parkinson's is more of a resting tremor and typically unilateral. So that's a very big part of it. Myoclonus, brief sudden startle movements, can occur in different ways. Tics, Tourette syndrome is another common condition that movement disorders sees. Actually, restless leg falls into a movement. A lot of times, patients are being referred in through different pipelines. They've seen internal medicine, they've seen orthopedics. They've seen like lots of different things, and it really turns out to be restless leg. That's a very common syndrome. About 10% of the population has some form of restless leg, and I'm sure some of you'll encounter. Various gait disorders, and sometimes you just lead to basically you're coding it as a gait abnormality, like that we've ruled out all of the other sort of movement disorders, and it really kind of pinpoints to a gait imbalance disorder. Spasticity, typically after a stroke or in the context of multiple sclerosis, cerebral palsy, or traumatic brain injury. Most movement disorder specialists have a basically level of expertise in botulinum toxin injections, as well as baclofen pumps and things like that. So that's where spasticity comes in, and then a rare condition called stiff person. So we could add other things like Wilson's disease and things like that to this list. But when you're thinking about movement, you're thinking about abnormal involuntary movement. And then you break it up into hyperkinetic movement, which is like too much movement, which we see as forms of chorea or dyskinesia, or hypokinetic, which is very common in Parkinson's, which is a term called bradykinesia. So this is just a case study that, I kind of thought was interesting. Basically, you have a 46-year-old gentleman. he's coming and he doesn't notice his symptoms. And we see this quite often, that it's usually a spouse or a care partner that may notice symptoms, especially when they're quite subtle. He's young, but actually we have many patients who are in their 40s and 50s when they're diagnosed. So the wife notes a decreased arm swing on the right, a little bit of drag of the foot. She was concerned because his mother actually had PD for about 22 years before passing away at 75. And, he's actually not that aware of his symptoms. So I thought this was an interesting case in that it's not always that overt. We often think of Parkinson's being a very severe tremor, that it comes out. And actually about 30% of patients won't have any type of tremor when they have Parkinson's. So there's many different forms. There's a tremor dominant form, there's an akinetic rigid form, and so on. So this is a very subtle presentation. And you might see this when you're doing just a regular annual routine with a patient, that you might notice that they're not dragging their arm, or the foot's scuffing a little bit. And I can't tell you how many referrals we get that turn out to be Parkinson's, because it is important to diagnose early, just so that we can kind of educate and treat accordingly. And Parkinson's is very interesting. So in order to make a diagnosis of Parkinson's, there's 4 cardinal features. One of them has to be bradykinesia, so that has to be slowness of movement, typically unilateral. But then tremor, stiffness, or slowness can occur, as well as postural instability. So by the time someone is actually diagnosed with Parkinson's, clinical onset, they've lost about 60 to 80% of dopamine neurons already. So there's this whole kind of prodromal phase, which we're not always looking at. And I think this is really where it's very important to be aware of some of the prodromal symptoms, because if you can actually catch Parkinson's, earlier on because of some of the prodromal symptoms, you can help to guide that diagnosis, so it doesn't become such an abrupt sort of, diagnosis for patients when they develop the motor symptoms. So by the time really someone reaches clinical onset, they've already lost a lot of the dopaminergic neurons, and hence you can see the pathology is in the substantia nigra. That's essentially where dopamine is made, and there's Lewy body deposition because of alpha-synuclein. But prior to this, there's a prodrome that occurs, even 20 years before. And so if you see patients that have loss of smell, constipation, anxiety, depression, those are all really common prodromal or premotor stages. One of the most common ones is actually something called Rem Behavioral Disorder. This is when patients in rapid eye movement sleep, when our bodies are supposed to be paralyzed and the only thing moving are our brains, they lose that ability. And so there's a lot of talking in the sleep, yelling in the sleep, there's restless dreams, and there's even injurious behavior. They can hit a bed partner. Some patients can sleepwalk. So that's actually a very common prodromal symptom that occurs even prior to the diagnosis of Parkinson's. So in a case like JP, you're thinking, okay, yes, he's showing symptoms now. They're super subtle, but guess what? That's not the start. Already there's been pathology occurring in the olfactory bulb, the enteric plexus. There's a lot of GI issues that go on. The raphe and locus cerealis, which makes serotonin and norepinephrine, which account for a lot of the prodromal symptoms. And then again, upon diagnosis is when it's hitting kind of the dopaminergic loss. And then, this is like in terms of Parkinson's, it's very different than a lot of other neurological conditions that you might see a patient once or twice, and then they, you do some testing and they go on their way. When you see a patient with Parkinson's, they really do become yours for the duration. So there's, many different stages that occur. Typically stage 1, like we saw in JP's case, it's unilateral. There's a bit of a tremor in some cases. It's, what we call the stage 1. Symptoms are mild, not super impactful with quality of life. Many of our patients continue to work full time and so on. But as things progress, and I'll show you in the next slide, the Brock hypotheses, symptoms tend to go bilateral. So go from unilateral to bilateral. And then when they get to a Hohenauer stage 3, that's essentially where the balance comes in. So basically postural instability, patients tend to have falls, freezing of gait, they're just not as stable on their feet. And then stage 4 is basically falls, dependency, and then cognitive decline. And unfortunately, the stage 5 is, sometimes about a 15 to 20 year plus duration in which there's a lot of cognitive impairment and patients are more incapacitated. I do think, though, that since I started practice, you're seeing a lot less patients in the 4 and 5. I think the cognitive piece is there, but we could do a lot more with the motor piece, which I'll show you in a bit. And this is the pathological staging of Parkinson's. So as I mentioned in JP's case, we don't want to just say, okay, he's already, he's in an initial stage. He's at that, part where the dopaminergic symptom is occurring. He's symptomatic. That we want to consider this whole pre-symptomatic phase. So you do want to ask him about things like smell and sleep and mood and things like that. So, Brock and Brock were a team of husband and wife neuropathologists, and they basically staged out the brain as to where different phases occurred in the context of Parkinson's, and defined 6 stages that really are attributable to pathology, which is the Lewy body deposition, alpha-synuclein overaggregation. There's lots of different cascades of pathology that essentially occur. So about the time someone is diagnosed, you're talking about midbrain, the dopamine cells, but over time, pathology continues to spread. So you get the thalamus, you get subcortex, and then you get sort of neocortex, and then the final the cortical loss. And again, that's what accounts for constant, loss of non-motor symptoms or accruement of non-motor symptoms, especially the cognitive piece. So it is important to think about a Parkinson's patient not as just a static point in time, but think about sort of the prodrome and really the clinical course that they take, because treating a patient through each course is very, very different. So, you probe a little bit further, you see that he had 2 concussions during high school, just takes some seasonal allergy medication. He works in a paper factory. His mother, again, had PD, and really no other, neurologic history. So it's important to realize there's no implicated causative factor that's been developed. You could say, well, the paper factory, potentially, could that be pesticides? Potentially there is a genetic predisposition in that his mother did develop it when she was in her 50s, but true genetic Parkinson's is fairly rare. That's usually much younger. But this is kind of alluding to how does a patient get Parkinson's? So it's kind of a 2-hit theory in that we think that someone might be genetically predisposed, and then they just never develop Parkinson's, versus, someone that might be genetically predisposed and then something in the environment, kind of goes along and knocks it into play. So those are things like pesticides, herbicides, rural living, exposure to well water, but again, nothing that has been definitely implicated in the cause. So it's still very idiopathic. It's still, we're not sure. At Mount Sinai, we do have a very robust genetics department. So we are able to get genetics a lot easier than, some of the other centers. We will usually get genetics on patients who might be younger, like JP's case, someone that has a strong family history, or sometimes certain, backgrounds, like there's a database looking at Ashkenazi Jewish people and things like that in terms of getting the genetics, just to see if we can align patterns and so on. So that's kind of important to probe more into the background. So we talked a little bit about the motor symptoms in order to make a diagnosis of Parkinson's, which would be slowness of movement or bradykinesia, tremor, not in all cases, but if someone has it, it's usually a resting tremor, stiffness or rigidity, it's a cogwheeling type rigidity, and potentially gait changes or postural instability. As of now, there's no definitive biomarker to make the diagnosis. We have a test called a DAT scan, which is a dopamine transporter scan, which can be helpful with regards to alluding to diagnosis. It's basically a scan that is looking at how the dopamine is being transported. It's done through nuclear medicine. And if it's abnormal, it's more suggestive of Parkinson's. If it's normal, it's not. So it could be good in cases where there's like Parkinson's versus essential tremor and so on. But to make a diagnosis of Parkinson's still to this day remains very clinical. And again, it's not just asking about the motor symptoms, but we talked about that prodrome, we talked about that postdrome. The non-motor symptoms are so important to recognize in a patient with PD. We have data that shows the non-motor symptoms are actually even more disabling than the motor symptoms. And these include things like neuropsychiatric symptoms, depression, anxiety, cognitive changes, psychosis, particularly as the disease progresses and patients need more medication. Impulse control disorders are a big one, especially again, as patients go on certain medication, especially dopamine agonists. Dopamine dysregulation syndrome is interesting in that, patients take their medication just to kind of function throughout the day, the levodopa typically, but over, some patients do dysregulate because they do feel better with it, but that's a syndrome. And then even repetitive behavior. So neuropsychiatric is very, very important. Again, here at Mount Sinai, we have such a good dedicated kind of team of our psychiatrists and psychologists that works with me for most of my patients, especially my deep brain stimulation patients, because we know that the neuropsychiatric aspects are almost as important as the motor aspects to treat. Autonomic is very important. Again, it can occur very on, but these are things like constipation, hypotension, excessive sweating, sexual dysfunction, orthostatic hypotension is important. For vitals, we do like to get orthostatics on all our patients because about 20% of patients with Parkinson's will develop orthostasis. So if you are seeing a patient, I encourage you to do a sitting to standing because many of the symptoms they do experience, lightheadedness, fatigue, even cognitive changes, sometimes can be attributed to orthostasis. Sleep is super important. Patients with Parkinson's really need sleep for neurorestoration, to make dopamine, the serotonin, and all the things that they are lacking. So if a patient is not sleeping well, they're just not going to do well. Most patients with Parkinson's can fall asleep okay. It's just that they're up every couple of hours. That's called sleep fragmentation. They can also develop excessive daytime sedation. As we mentioned, restless leg is a big one that occurs as part of the Parkinson's complex. The Rem Behavioral Disorder, which is, again, the yelling, talking in sleep, the vivid dreams. But the sleep-wake cycle can be very disordered in Parkinson's. And one thing you want to ask every single patient with Parkinson's about is, how are you sleeping? Because if you can really work on their nights, you can really lead to better days. And I know like it sounds paradoxical, but it really does make a difference. And then, sensory changes were actually not thought to be Parkinson's before, as a separate entity. Now we actually see that patients do develop numbness, tingling, sometimes burning pain. And we talked about loss of smell. And sometimes vision changes like double vision. So these are all really, really, really important things to like really kind of run down with a patient with Parkinson's. We do have a scale called the MDS Unified Parkinson's Disease Rating Scale, which is a great scale in that it is allows you to ask about all of these types of motor and non-motor symptoms, in a much more kind of meticulous fashion, and then it leads to a good motor examination. So it's really important to make a diagnosis and treat a patient to talk about motor and non-motor. So say a patient with JP was diagnosed with Parkinson's, you can do a lot of different things. You can treat with, many different medications, and I'll go back to the 9-year later. But when someone is diagnosed with Parkinson's, this is kind of a loose algorithm because there really is no algorithm, I'll be honest. It's very, very different. Every patient is so individualized, and you really have to take into account age and psychosocial status and, level of functionality. We have many patients who are young and still working full time, and versus other patients who are a little bit older and, develop mild symptoms. So it really is important to get to know your patients. This non-pharmacologic intervention is crucial. You really can't move on to, pharmacologic intervention unless sort of the non-pharm is addressed. And that's things like sleeping well, exercise. Right now, exercise is the only thing that we know that slows the progression, that's disease modifying. So, we really, really, really want to, make sure patients are aware of the level of exercise they need, various community resources. There's a ton of stuff in the community, it's even through Mount Sinai, our social workers are great. We have boxing, we have, the big and loud therapy. There's so much, but the sleep, exercise, diet, make sure they're drinking enough water, especially if they're prone to hypotension, and then just stress reduction, trying to get patients to socialize, things like that. But the lifestyle measures for Parkinson's are absolutely crucial. And then when you get into pharmacologic intervention, you weigh out, is there functional disability? Do we really need to start medications? And medications you don't need to, and you can kind of watch and wait. Again, disability is not just what you're seeing objectively on exam, it's what patients are telling you. I have many patients who are very, very mild on their scores on exam, but, symptoms, especially if it's tremor or something, are impactful with work or, various things. So we treat first, someone that has more disability. And, this is really a hodgepodge of things because there's no right or wrong. Carbidopa, levodopa is our best medication. It does not loses effect, but the window narrows with how much you need to take. And then there's other things you may want to add. First, in a younger patient, you can start an MAOB inhibitor, dopamine agonist. So there's really no right or wrong. I think the key is finding the right regimen that's going to optimize how a patient is doing, is going to be clinically efficacious, but also minimizing adverse effects. So say that JP was started maybe on an MAOB inhibitor, he was young. Eventually, most patients within about 3 to 5 years will be started on levodopa. Levodopa, the other name is carbidopa, levodopa or Sinemet is our gold standard medication. It's the best one that we have. And still to this day, even though it was developed in the late 60s, really does remain the gold standard. Right now we have different preparations. We know a lot more about the GI tract and absorption of levodopa, but it still is our gold standard that, 90% plus patients will eventually be on. So he's now 9 years later. He was started on levodopa. But it's not only lasting about 2 hours. He's having to take more frequent dosages. So when a patient, needs more levodopa, that can result in these dyskinesias, which are really kind of abnormal, involuntary writhing movements. And that's when patients kind of develop this roller coaster where they're fluctuating between off time and then his on time is limited with dyskinesia. So we're seeing that in his case. He doesn't have that much good on time. He's requiring assistance with ADLs, especially when off, and then when on, he's having dyskinesia. He also might be having a little bit of impulse control disorder because he's at the gaming saloon and refuses to come home. So that's another kind of non-motor symptom that's important to ask for, especially when a patient is on high doses of levodopa. And he's on it around the clock, as well as ropinirole. 24 milligrams. So that's like the max dose of ropinirole that you can take. And that's likely attributing to the impulse control disorder. So not only is he affected motorically, when you're really fluctuating between on and being able to function and eating meds every 2 hours, but then that on time is complicated by dyskinesia, and then you're fluctuating off, you really have to figure out for these patients, what can I do? How can I give them more on time? And then, not just the motor piece, but you have to take into account the non-motor. He now has psychological issues, the impulse control disorder, which can be very devastating. And so you're really having to weigh out so many different facets. And this is where it gets a little bit tricky. We know that levodopa is our best therapy. When patients start Sinemet or carbidopa levodopa, we call it the honeymoon phase in the beginning. It has a nice response threshold. You can see in green, this is the therapeutic window that patients don't have to take that many. They may take a dose every 3 times a day. They're having good response. It's lasting 6+ hours and they feel good. And there's a low incidence of dyskinesia. But over time, and this is really through striatonigral degeneration because you have continued cell loss and basically the pharmacokinetics of levodopa, that window gets smaller and smaller. And so patients need more doses. The threshold for dyskinesia goes a little bit lower, and then the response is much less. So what might have worked for 6 hours really goes down to 3 or 4 hours. And patients, that's when you start to see them take a lot of medication. And then we see that, a patient like JP in the case study is a lot lower. You can see that little therapeutic window in the stripe is really, really small, that he might take a medication. It's only lasting him 2 hours. It's a short duration response. And his on time is associated with the dyskinesia. So this is really where you got to think about a patient that's on levodopa. It's important to think about their therapeutic window, and as to how much response are they getting, how long is it taking for the medication to kick in, when is it wearing off, do they have dose failures? And the key really is to treat a patient, get them in that bullseye window, really, really into that kind of therapeutic window. It makes a tremendous difference if you can kind of keep them there. So again, this is meant to be confusing because there is no right or wrong. And so the strategies that you can use for someone like him, he's younger, he is having motor fluctuations, you can add more levodopa. There's other medications, but we have this red box here that dyskinesia is increasing. So you can't just increase his levodopa because of the dyskinesia. I would get him off of a dopamine agonist because of the impulse control, but then that's going to lead to more bradykinesia. There's other medications like MAO-B inhibitors, amantadine for the dyskinesia, COMT inhibitors. But the key here is trying to figure out the best plan of action. And it's not always medication, and that's where neuromodulation or deep brain stimulation plays a big role. But the concept of Parkinson's, and we see this all too often where patients were diagnosed, they were started on levodopa, and then nothing else was thought about. They were just, the levodopa was increased and increased and increased. And they come in sometimes on 3-4 tablets, 4 or 5 times a day. And that's, really, way too much. So I think the key really is this concept of rational polypharmacy. And yes, we can use our gold standard, we can use levodopa, but keep in mind that therapeutic window, keep in mind, the fact that there's that lower dyskinesia threshold, and what can we do to open that up a bit. Polypharmacy with things like amantadine, anticholinergics, entacapone, MAOB inhibitors can allow for more on time. You just have to weigh out the side effects and so on, because so it becomes a big challenge. I think this is where movement disorders plays a big role with evaluation, and then just trying to figure out the right way forward, because there really is no template or paradigm. The other thing is, beyond the oral options, we know that in Parkinson's, about 70% of patients have gastroparesis. So the medication, might be taken, but depending on when they ate or what they ate, or even non-dependent of that, the medication just does not get absorbed. And so over the last couple of years, there's been a big push to what can we use that's non-oral? What can we use to bypass the GI tract? So you might see a lot of patients come in and on different preparations, and that solely is just for absorption. So we do have subcutaneous injections, we have infusions that will be available pretty soon. Right now, we do have the Levodopa Infusion, which is done through basically a J tube that goes into the jejunum. That's a constant 16-hour infusion of dopamine with a ability to bolus. We have a transdermal patch, which is a dopamine agonist that's available. But we still have a big unmet need, I think, for better oral, non-oral therapies to play a role. Deep brain stimulation has been done since 1997 in this country. Mount Sinai is one of the forefront centers in the country that does it, and it really plays a tremendous difference with opening up that window. The history of it was interesting. Basically, it was found that in the 50s, when patients during a thalamotomy, that high frequency stimulation produced tremor arrest, and that was actually done through a patient that was going for a vascular procedure where the anterior choroidal artery was inadvertently snipped. And so basically there wasn't, it was essentially called a thalamotomy. And all of a sudden you saw the tremor just get better, even though it was not meant for that. So really in the 80s, there was a renewed interest for surgery for movement disorders. The ablative procedures in the past had a lot of chronic side effects. And so thought was, how can we kind of cause an ablation, but use stimulation, so we're not ablating. And so this is kind of where there was a lot more advances in sort of the basal ganglia and the underlying pathology for targets for Parkinson's, which are globus pallidus and subthalamic nucleus. For essential tremor, it's essentially the VIM thalamus. So again, the advantages of deep brain stimulation, it doesn't involve destructive brain lesions. Bilateral procedures are associated with minimal risk. Instead of lesioning, you're stimulating. The stimulation is really pretty interesting in that it can be continually optimized. There's like 50,000 plus settings. There's 3 different systems out there. It's pretty amazing. So my team and I, we really work to find the right settings and really kind of maximize optimization of symptoms and minimize adverse effects. And then because you're not ablating, if anything comes out that really depends on the integrity of the basal ganglia, gene therapy, and so on, it can still be used. In some cases it is requiring electrodes, it's surgery, it's hardware in that, there's an implanted device. The battery sometimes needs to be replaced, although we do have rechargeable. So there are some advantages and disadvantages, but it really is important to weigh each out. So in a case like JP, there's a lot of things you could do. You could opt for the polypharmacy. He was having dyskinesia. If he wasn't already on amantadine, I may consider that. I would have definitely gotten him off the propinerol with the impulse control, had psychiatry, be my team partner in managing him. And potentially, though, he'd be a very good candidate for deep brain stimulation. He was young, seemed to be cognitively intact, but really just not getting that optimization of the therapeutic window. And deep brain stimulation is essentially using neuromodulation. So you can almost think of it like an electric version of levodopa. In a way, you're modulating the circuit rather than just taking a lot of dopamine to drive the circuit. So I think that would have been a great candidate. One thing I wanted to mention, and I was really pleased to be a co-author on this book that was published, was basically we wrote a book on Parkinson's disease for the hospitalist. And this is so important because we know that when patients with Parkinson's go into the hospital, whether it's a routine admission, it's an emergent admission, it's for surgery and so on, they don't do well at all. They're more susceptible for complications, medications that they've had down at home, like that they take 8, 12, 4, and 8, for example, like Q4 hours, gets misread as QID. So it's like 6 a.m., 12 noon, 6 p.m., 12 a.m. Definitely patients are told not to get out of bed, and especially we want patients with Parkinson's to be as active as possible. There's contraindicated medications that they're sometimes given, things for nausea, psychiatric, especially if they do develop some delirium and things like that. And so the goals are safer hospitalization, a shorter length of stay, and just a better experience for the patients and their caregivers. So one of the biggest pushes right now are really to kind of identify patients who have Parkinson's, no matter what stage, and really sort of pay a little bit of special attention as to the medication, the physical therapy, trying to get them out longer, and then minimizing meds they're started with. We see a lot of patients with Parkinson's go into a hospital, then they go to like a rehab center and they're put on lots of meds, which they continue on. So, I think this is really, really important. And it was something that, was really important for us to write, just because the goals are just a good hospitalization and really trying not to worsen a patient with Parkinson's. I think that's very important. And then, I think just it's really important to realize Parkinson's, Huntington's disease, essential tremor, dystonia, any type of movement disorder requires multidisciplinary care. You can't really do it alone. So the patient is in the middle. So it's not just the neurologist, it's not just the movement disorder specialist. We have the most fabulous physical, occupational, speech therapists, social workers that work with our patients. Our primary care, internal medicine groups are crucial. I mean, it's so important, like across EMR, to be able to share notes and, share thoughts and so on. Family, caregiver, I mean, things like that. But I think the key really is just making sure that our patients with any type of movement disorders, especially like someone like Parkinson's, are really well taken care of and are given the adequate resources, and then a better understanding of, more than just levodopa, that there is so much more that exists. So that's sort of the case study there. If we wanted to maybe talk a little bit about any other movement disorders, if we had questions as to regards to, anything else that I do or assessments, I'd be happy to take that.
Thank you so much for that, Dr. Gupta. If anyone has any questions, you can feel free to unmute yourself or ask in the chat if you have anything related to Parkinson's disease, or I guess any specific questions about other movement disorders.
Yeah, I have a question. I'm Joseph, one of the second years. Thank you for the lecture. So my question is it possible for the autonomic dysfunction to be the first presentation of Parkinson's disease? Or is it like usually happens at the late stage, or like multisystem atrophy or tri-dragger?
Sure, so that's a great question. So actually one of the early prodromal symptoms is constipation. So I mean, that could be considered a bit autonomic, but we actually are seeing, and I was part of a paper that we found that there's Lewy body deposition in the gut and so on. So constipation can occur early on, but typically if someone's really dysautonomic with orthostatic hypotension, urinary issues, constipation, in the context of Parkinsonism, it's probably going to point to more of an atypical form, which is, as you mentioned, something like multisystem atrophy. In those cases, it's hard to sometimes delineate, and it looks exactly like Parkinson's from the start, but over time, they may develop within the first 1 to 3 years. The autonomic disturbance, whereas a patient with idiopathic PD, it's usually much later, except for the constipation.
Fatma just had a question asking which meds we should avoid for patients with Parkinson's, like Compazine, Reglan, haloperidol. Are there other ones, or I guess best way for people to remember those?
Yeah, absolutely. So any of the antiemetics, the only one that is kind of loosely recommended is Tigan, which sometimes can be hard to get, but you really want to try to avoid Reglan, especially, and Compazine. They do block the D2 receptors. Haloperidol also, or any of the older generation typical antipsychotics really should be avoided. Even the atypical antipsychotics, if you can, especially things like Zyprexa or Abilify, can worsen a Parkinsonism. The ones that we work with are things like quetiapine. Usually it's our first choice if we're going to go to an antipsychotic, or clozapine, which has a much less dopaminergic blockade. So yes, absolutely, any of the antiemetics or the antipsychotics are things to really watch out for. I can't tell you how many patients come in and they've been on Reglan for years, and they tell me it's for like diabetic gastric issues or things like that, and it's really caused the Parkinsonism, and just by going off of it, they do see some response. So I think looking at a patient's med list is really super important.
And another question from Fatma, any problems if we delay restarting Sinemet for patients with Parkinson's? I guess if for some reason there was a delay, can you just restart kind of at the same time, same doses?
Yeah, it's a great question. So there's still this debate about when to start Sinemet. Do you hold? You know, when I first started in practice, I mean, it was like, oh gosh, you only start it like when a patient needs it. Now the data shows that, or you hold as long as you can and you really kind of push a patient. Now we see that as long as you start it and you keep the doses judicious, you don't like overdose, or you keep it at a really kind of good, like usually about 3 or 4 times a day, 3 to 400 milligrams, it's okay to start. There's no problems with delaying because Sinemet is not a disease modifier. The only problems with delaying would be like if a patient needed it for work or something like that, and it really impacted sort of quality of life. But at this point, the only thing we know that modifies the disease is really lifestyle or exercise. So delaying it only may impact quality of life, but it's not going to change the disease course. And now we know nor is starting it early either.
And I guess for any reason, if you had been holding it, can you just resume it? Like, I don't know if the patient didn't fill their medications, or I know sometimes like during procedures, if for some reason the team accidentally held it, can you just resume at same time, same doses? And I guess one thing I was wondering, because it comes up a lot, I guess, when we're doing preoperative evaluation and post-op, are those patients that neurology want to be involved in, or be called to see if the patient is like otherwise well controlled, and how do you manage them kind of during the operative period?
I think it's a good question. I think it's always very helpful to have neurology on board because it can be tricky, and especially with these types of medications where there can be withdrawal and so on for it. So I think it is helpful. Yeah, I mean, you want to be very careful. You never stop Sinemet. I mean, yes, we see it all the time. Patients couldn't get their medication, or they make call in time and they go off. You want to be very careful of sort of stopping any of these PD meds abruptly. But when you go on to restart it, typically we'll go right back to the dose that they're on, unless there's like tolerability issues where we taper it up. So, but yeah, I think having neurology involved, especially as like sort of the post-ops and things like that, is always helpful.
Kirtana just had a question. Do you treat PD-associated gastroparesis with levodopa dopamine agonists or agents like erythromycin, or what would your preferences be in those scenarios?
It's a great question. I mean, there's really no consensus. Even our gastroenterologists are really out in terms of what the best approach is. Right now, probiotics and things like that might be recommended. We're not using erythromycin. I think just more awareness of the GI pathology is really super important, because there's nothing worse than a patient taking their meds and it just doesn't work and they're incapacitated for hours. So again, that slide I showed of non-oral options is sort of what we're thinking about in terms of ways of kind of bypassing the gastroparesis. As far as diet, we recommend typically smaller, more frequent meals. That sometimes can help with a lot of water and hydration, a lot of fiber as well to kind of minimize constipation. But so there's some dietary measures our dietitians like to do, but right now we're not directly treating the gastroparesis. It's just that we're more mindful of it neurologically.
Thank you. Any other questions or comments if anyone wants to unmute themselves or post in the chat?
Hey, I just want to say thank you. I'm the PD. I wanted to ask, is DBS usually covered by all insurances, Medicaid as well, or is it more the private insurances?
Yeah, that's a great question. No, it's actually really widely covered. Again, it's been done in this country since 1997. Mount Sinai was one of the first, enrollments in the country. Right now, for Parkinson's disease, essential tremor, dystonia, it's covered, whether it's Medicare, Medicaid, private payer. We have a whole reimbursement team too that helps. And then hopefully when it comes to fruition for more psychiatric conditions, that will continue. So yes, it's absolutely covered.
Okay. And I also want to ask, so for essential tremor, when you're seeing these patients in the office, is there any drug that you like to go to? Because I know, sometimes it'll be benzos, it'll be beta blockers. Primidone used to be used years ago. I'm just curious, what's the latest?
Yeah, the hasn't changed that much. So again, essential tremor is a bilateral kinetic tremor. Patients perceive it with action eating, drinking, handwriting. We try the non-pharmacologic approaches like wrist weights, occupational therapy. It's also about like how impactful it is to patients, how much of an impact. When we go to treatment, this treatment still is a beta blocker as frontline therapy, typically propranolol or using Inderal long-acting. If you need to add a medication, again, it has the theory hasn't changed much. It's then going on to something like primidone or mycilline. Or if a patient has a contraindication or can't tolerate a beta blocker, you might try primidone or mycilline. The third, fourth, fifth line therapies are things like gabapentin, sometimes topiramate. We try not to use the benzos unless, we really kind of have to, or there's like an anxiety type component along with it. We just find that, there's a lot of breakthrough tremor and there's more side effects there. So we're seeing a lot more patients go right to therapy for deep brain stimulation. And now at Mount Sinai, we just brought on high frequency ultrasound, which is basically creating a lesion, but done done through more of like a radio frequency wave. So it's not invasive. So I think as a whole, there's much more options, but it's still kind of propranolol, primidone or the top two.
Right. Okay. Thank you very much.
I think if there are no more questions, comments, then we can maybe leave it there. But thank you so much, Dr. Gupta, for a great lecture.
Oh, thank you so much. It was such a pleasure, guys. Take care.